one.
I appreciate you being here today, and this is, a project that we're doing for school, but I also really believe that this is something that needs to be done. We've got the DMV coming next week, and it's important that we document our pain, in the ER, and we do fall kind of short, so thank you so much for coming today. I'm going to flip through a couple of these, too important just for this program. But most patients, when you say they come to the ER, most of them are coming for pain-related reasons. But when you're looking at the research and even looking at our patient charts, it's showing that we don't document pain the way that we're supposed to and the way that JACO would ask us to do it. So there's a lot of implications that are going to happen if we're not documenting pain appropriately. What I'd like to do is improve the pain management here in the ER and also at least the documentation at best. So what is pain? Pain is an unpleasant sensation that can range from mild localized discomfort to agony. And when you talk about pain, it has both physical and psychological implications from it. How can ineffective pain management affect your patient? Sid, how do you think it might, affect your patient?
Their healing process is slowed down.
Definitely. So that's one good reason why we should do our pain management a little bit better. So some ways that it affects your patient is it causes undue suffering, a decreased quality of life, lost productivity, and at the end of the day, you have a lot of healthcare costs because they have return visits. Now, what does this mean for the ED? Good gosh, the waiting. So this is what we always get. How long is the wait? How long is the wait? And how long is the wait? So as you know, that if the patient is waiting, generally we're not turning our beds quickly enough. So some of the delays that can happen if you're not managing a patient's pain, and I know that some of y'all know this from the ER, they won't get their x-ray done. You have a delay in treatment at that point. They won't go to CT because their stomach's hurting, or they got too much pain, or suddenly they're vomiting from their medication. So there's a lot of things that will keep the patient in the bed and not turning it over. Suddenly when you go to discharge the patient, well, I'm in pain, nobody's done anything about my pain. So, and how do we know? Well, we're not documenting it either. So when you're looking at the patient's chart, you have no way of saying that, yeah, we're taking care of your pain because we're absolutely not documenting it. So how long is the wait? How does this affect your ER? Prolonged stays in the ER, repeat visits to the emergency department, delayed patient bed and room turnover. And also another thing to consider is that your hospital the reputation may suffer because of the patient satisfaction scores. Everybody does the Chris Gaines these days, and it's public information. And so if people are reporting that we're not taking care of their pain, then it's going to show in the public records. So we want to make sure we're taking care of our patient. How is this going to be good for both of us? So let's just say that if we're managing our pain, according to JACO standards, then we're providing therapeutic communication with our patient. This builds patient trust with us as the provider. The pain is generally managed better because they feel like we're taking really good care of them. And repeat visits, hopefully in the future, should be at least reduced a little bit. So everybody benefits from that. So when it comes to this project, the objective of it was to improve the overall effectiveness of pain management by actively assessing pain, checking it periodically, delivering interventions, and to, at the end of the day, make sure we're documenting it in the patient record. The patient has a right to pain management and pain control, and they should be treated as such. Why do we care about this? Well, we have plenty of safe and effective treatments for pain, but consistently we're relaying a phenomenon of undertreatment of patient pain because it just seems like everybody is here for their discomfort and it's not being managed appropriately. So in research, it's showing that there are significant functional impairments that pain can inflict on the body. And so to improve patient outcomes, we must control their pain. And if you think about it as a nurse, that we are in the business of improving patient outcomes, making sure that they're well and feeling well. So that's one of the things that they are guaranteed it needs to be taken care of when they come to the ER. It's a right that they have. According to the Joint Commission, there's a few things that we have to be doing that we're not doing very well right now. So every patient should be screened for pain. every patient has to have a pain scale documented on arrival. There needs to be an intervention if a patient is experiencing pain, and once the intervention is done, then we need to document a response to that intervention within an appropriate amount of time. And before they go home, they are supposed to get pain education. It needs to be provided to the patient, at least to the family too. So when it comes to our documentation here, there are some deficits. So one of the root causes, I believe, is that we don't have enough motivation. There's minimal motivation to change current status quo. A lot of times we sit around and we think about our pain drug seekers, our pain seekers, our repeat visitors, and our frequent flyers. However, we need to probably change the way that we feel about our patients, especially in that arena. In nursing research, we always have a PICO question. So the question that we're asking, or that I wanted to ask, was in hospital patients who have complaints of pain, will proper assessment and treatment of the pain improve the nurse's adherence to J-code, the Joint Commission guidelines for pain management? And if the guidelines are consistently met, will patient outcomes improve over those patients whose pain has not been managed effectively during the course of their ER visit? So we've done some research on this, and the research is going to prove that we have to probably improve our patient care and our patient pain management. I found it pretty surprising in this particular study by Garduf, Lawman, and Nielsen that at the conclusion of the study, they found that 52% of patient records, only 52% were documented pain assessments on arrival. And out of all of that, only 88% had a full pain assessment. 19% documented a response to the treatment. So it's really a significant lack of documentation that was proven in this study. And I believe that, here that we could probably also do a little bit more better. So when it comes to the evidence, we probably should talk a little bit more about what pain's going to do to you. So how does pain affect our patients? Well, pain is often referred to as the fifth vital sign, and it can cause profound negative effects on the patient. So some things that you think about, what do you think it might do to your patient?
Affects mobility.
Yeah, it does affect their mobility. I mean, sometimes if you have chronic pain too, you're laying in the bed a lot. Sometimes we'll get rheumatoid arthritis patients who don't get to get up that often, and when they're up, it just takes forever for them to get up, and they're in so much pain.
It also causes them risk, like pneumonia, DVTs, if they're going to be bedbound because they don't want to get up because they're in so much pain.
Yeah, most definitely. And those are some of the things that we need to think about when, just because we're not in pain doesn't mean our patient's not in pain, and certainly chronic pain too. So they can suffer high blood pressure, cardiac ischemia, paralytic ileus. Again, it affects your mobility, and it can cause lung issues. There's actually a study, Sampson did that, and it showed that this is some of the proven effects of poor pain management. Some more research was done, and it said that, in this particular piece of research, it doesn't really prove that we're not doing a good job. It just says that maybe we're not, well, let's see, not this research, I think the next research. This research here says that when a patient's pain management plan is understood by the patient, that their outcomes were a lot better. Their pain was easily managed at home, and they didn't really have a need to return to the hospital very often, although they were even a cancer patient. So even in cancer pain, pain can be controlled with the patient at home if there is a full understanding of what's going on. And then here's some research that says something we might need to take more attention to is in our elderly, or those who are cognitively impaired. Because they can't speak for themselves, it's often difficult for us to understand what's going on. And, they're laying in bed, and we can use a face pain scale, but sometimes, that's just not good enough, I don't think. So it's not easily controlled in the elderly and the cognitively impaired. So probably we're going to find a place where we need to deliver some better education on how to take care of those patients. And again, another study, so not only is it physical with these patients, it can also have psychological implications. There's a level 3 cross-sectional study that I looked at, and higher pain was associated with greater fatigue, anxiety, and sleep disturbance, and this caused an increase in depression too for these patients. So if your pain is not controlled, you don't really get out too much because of the pain. You're not sleeping well, and of course you're going to be in a more depressed state. And again, it's kind of a cyclical thing. You've got the pain cycle. Patient has pain, it causes a disability, or they got pain from disability, and then of course they've got distress. So it's just all the time, just kind of rolling. Anxiety, depression, disturbed sleep, loss of independence, and then they withdraw from social interaction. So when we talk about change here in the ER, it's not just going to happen on its own. There absolutely has to be a plan. And so some of the key factors that are going to make this plan successful is gain leadership support, and I've already done that. I've gotten support from a couple of our key leaders around here that said that they would be more than happy to kind of support this plan of action to get us to change. So staff involvement is going to be important. Make sure your objectives are clear, and while we're doing the project, that recognize all the small milestones and don't just wait till the end results to recognize if there's been a positive change or not. We need proper planning, and then at the end of the day, we'll evaluate the plan and see if there's any changes that need to be made. And again, so some of the recommendations for the change will be to engage the support of management. Well, we've done that. So another thing we'll do is develop a team of colleagues, and I've already talked to some of the levels nurses, and they're going to be engaged in this also. They'll be evaluating approximately 100 charts to see sort of where the baseline that we are right now, to see where we need to go from there. Some other ways that you can reduce the barriers of change is to address what we call the status quo, and those are the people or the ideas that we have that have just been around forever, and the idea that we don't really want to change. So we talk about the inadequacies of our current practice. And are they good? Are the steps consistent? We do pretty good in a lot of areas, but I think overall we're definitely missing the boat on documentation. And one thing we need to do too, for sure, is make a plan for some educational needs. So we will update some of the pain management information. We also need to make it clear what happens to patients when their pain is uncontrolled. And we'll just be delivering this education through staff meetings. We'll also do this in staff huddles. We'll talk about the plan in action and what's going on. So we'll also improve employee involvement. And when it comes to employee involvement, that means we'll start by asking where you think our deficits are going to lie. So one thing I think about when we talk about our deficits are the time involved in the ER setting. So when a patient's in, you've got 3 or 4 other critical patients, they're not doing well. I mean, it's oftentimes very difficult to go back, reassess, make sure your charting's done, your 30 minutes after pain intervention or your 1 hour after appeal pain intervention. It's difficult to do that, we understand, but it has to be done. It's a JCO guideline, a CMS guideline. So we're gonna have to visit what's going on with that and how we can improve that. We'll get staff involved on this kind of stuff. We'll do daily updates. And another thing I want to do is get the clinical educator involved. I've already talked to Peggy about Paula about it. She said she's more than happy to do it. So peer coaching will be one thing she'll do. Check the patient chart, and if she sees a deficit, she'll actually come and directly discuss it with you instead of calling you out. Just discuss it with you to make you aware of what's going on and how you can improve. So I feel like once we get ED management on board, we've got clinical levels doing this. We do the education, we roll out the education program, and then we start sort of looking at the charts and doing the interventions with the clinical education manager. Then we'll be able to refreeze this into practice. So when it's all over and done, adherence to our guidelines, this is the hope, the adherence to our guidelines will begin to be revealed in the patient chart. So what we do is we unfreeze, we figure out what's going on, we figure out what the problems is, what our baseline is, we make our change, and then we refreeze it so it sticks. Once we put our key and our plan into action, what you want to do is completely evaluate it. You measure it, and that's what's going to determine the success of your program or not. So when we continue the refreeze and continue surveillance of evaluation of the program, we'll reevaluate for at least 6 months following the initiation of the change. We'll have continual surveillance of patient charts. We'll continually give positive reinforcements for the things that are gone wrong, the things that we're doing right. And we'll also recognize the competence and the improvements that we're making. And we'll always look for continued opportunities to improve So as we're continuing to do the surveillance on the charts and continuing to keep all this in everybody's mind, staff will know that if a proposed change is taking place, that we won't return back to our old practices. And at that point, it will be institutionalized into practice. I've got some questionnaires that I'm gonna pass out. This is something that we're gonna be doing with clinical levels. These are some of the things that we're looking for when we do our patient charts. So just kind of keep that with you. I thought that that would be something to prepare you for the future. Another thing I did for our little badges, we'll just kind of put them there. It's the more JCO guidelines. Kind of hang out with those on your little badge tags. And this will help you keep up with what JCO is expecting, especially the DMV coming next week. We really need to be up on it a little bit better than we've been doing. Anyways, any questions? Anybody got any questions about what we're gonna do? No. I expect it's gonna start in about the next week, and we're gonna go and get the clinical levels together and get that rolling. So anyways, I appreciate y'all being here. I know it's a little impromptu, but thanks for coming in. I got another class of teaching just a little while. So y'all go enjoy your shift. Thanks.
Thank you.
Thank you.
Yay, y'all.
Thanks.
I appreciate it. Y'all stopping by. I don't know how to turn these off. Just the red. It's okay.
Wow.